Welcome to this video presentation. My name is Struijker Boudier. I'm a pharmacologist and I was scientific director of the Cardiovascular Research Institute of Maastricht University and the academic hospital in Maastricht in the Netherlands. And this lecture has as its topic the combination of hypertension and hypercholesterolemia and the way we can deal with this problem. I have no conflicts of interest to declare in giving this lecture, and I'd like to move on to the learning objectives. And as you will see, we will discuss a few different aspects of this combination, which is occurring very frequently. And we'd like, at the end of this presentation, to have given more information and to allow you to screen high-risk patients for the combination of hypertension and hypercholesterolemia in order to ensure early diagnosis and prompt treatment. Secondly, in order to let you learn and name really the modifiable risk factors for hypertension and hypercholesterolemia. Thirdly, to assess how treatment, both pharmacologically and in other manners, the adherence of patients is with this combination. And finally, in a more recent development, describe the best practices for telemedicine support, using particularly a multidisciplinary team approach to this complex medical situation. Now, as an introduction, I mentioned already that arterial hypertension and hypercholesterolemia constitute both a dangerous combination, which is frequently seen in clinical practice, even despite a wide range of medications that are nowadays available for both conditions. And one may wonder why this is the case, and particularly see how we can deal about it. When we look at the next slide, you see that this is a slide taken from a classical study in studying the combination of hypertension and hypercholesterolemia. It's an American study published in the early years of this century and based on the early years of this century. And there you see, for both overall and individually for male and female patients, that the prevalence of this combination is around 20% at that time. And in the striped bars, the prevalence is the dotted bars, and in the striped bars, you see that only 30% or even a little less are treated for this double combination, this combination of both hypertension and hypercholesterolemia, whereas the control is even less than 10%. So at the beginning of this century, we were in an extremely poor situation in dealing adequately with this combination of cardiovascular aspects. Later American studies, much larger USA National Health and Nutrition Survey, which spanned the years until 2010, but were published a few years after that, confirmed that, and again showed that about 60% of patients with hypertension also have hypercholesterolemia. So it even increased as compared to the earlier part of the century, whereas the treatment again was increased. It went up from less than 10% to approximately 35%, but still 65% of the patients remained uncontrolled for the conditions that they were to be treated for. A very recent study that was published just a few years ago, it comes from Europe, the Polish multi-center population health survey, a large study involving both men and women. And again, the conclusion of that study was that the prevalence of coexisting hypertension and hypercholesterolemia is more than 30%, about 35%. So we really talk about a clinical condition that is quite frequent and again, dangerous because it combines two major risk factors for cardiovascular disease and mortality. Now, which approaches can we consider to tackle this inadequate control? There are a few ways to probably deal with this. I've summarized them here, and I will discuss them each in somewhat more detail. The first approach is, of course, early detection, to be really early in the phase of detecting whether both situations exist, whether in a hypertension patient there is also hypercholesterolemia or the reverse. And the next slide gives you a list of recent guidelines for the management of hypertension and hypercholesterolemia, large studies, large guidelines, more than 100 pages, which very detailed discuss that now. And that's certainly one of the advantages of the recent years, that both in Europe and the International Society of Hypertension, the guidelines for hypertension from the United States and from coronary artery disease, and even many individual countries or regions in the world have developed their own guidelines, but they are more or less comparable. There might be some differences, but in general lines, they agree. And each of these stresses early detection as a primary point, to be very precise in diagnosis and to detect the existence of risk factors. What these guidelines also do in much detail, next slide, is stress adequate treatment of both hypertension and hypercholesterolemia. And for both these situations, there is an excellent series of drugs available now. One can optimally treat if one wants to, and the guidelines, I will not go into all these details, of course, but in the guidelines one can read schemes of various types of drugs and the preference of using these agents. So if we go to the next slide, when we talk about the poor adherence, there is an important study published a number of years ago already, that one cannot rely on an adequate adherence of patients taking their drugs. This study by Blaschke, again published about 10 years ago, shows that within 1 year, the horizontal axis gives 1 year, the amount of patients that take the drug actually is reduced, or the doses adequately, to about 50%. So one loses within 1 year half of the patients just in not using their drugs adequately. So that's an enormous problem, and this should be part of course, training, educating the patients, and giving them information about the necessity to adequately take their drugs as prescribed. So apart from that aspect of education, another form of education is more and more, in the next slide I give this as the third approach to tackle the problem, as the third approach being education and also following up on the lifestyle interventions. Lifestyle interventions have become more and more important as part of the approach to people with cardiovascular risk factors, and in particularly hypertension and hypercholesterolemia. Lifestyle interventions are manifold, and the guidelines that I just showed go in deep detail which ones make sense and which ones do not make sense. There are still discussions going on. This is definitely not a topic where we have had the final word, but now we can rather well see what the different possibilities are to adequately come to lifestyle interventions that contribute to risk reduction. The next slide shows you some of these recommendations, and you can group them into 4 different aspects. It is movement and body weight control, so physical activity, really, food and nutrition and drink. So the whole nutrition aspect is very important. Body and mind, things like good night rest, relaxation are important aspects, and there are even other ones which in much more detail have been presented in the guidelines that I just showed. And the next slide is a slide with many of these details. It gives both for the movement, which types of movement, what sort of exercise, and also what is not done. It is in green what is useful, and in red some things that should not be followed in lifestyle terms. Food and drinks is a very comprehensive topic with many publications. Is it good? Is it bad? I would summarize this really in just one word. Probably the Mediterranean diet is, in terms of diet, the best approach when it comes to food and drinks, and many publications have given the details of that type of diet, and certainly a number of things should be avoided as well. Finally, the body and mind, and the other aspects are good night's sleep, regular sleep, meditation might sometimes be helpful. Music has even been claimed to have a positive effect on cardiovascular risk factors. And again, the guidelines I showed you give much more details on these various possibilities. So finally, a fourth aspect that is becoming more and more relevant in these last years is the follow-up over a longer period of time. The doctor is no longer only in the one-time visit in the office responsible for adequate treatment, but needs follow-up on whether both the pharmacological and the lifestyle interventions are pulled up adequately over a long period of time. And if you look at the next slide, you see this is a multidisciplinary team approach, not only the physician who is treating, but also the pharmacist, who plays an important role in the drug intake and the compliance to that, the dietitians, the use of adequate feeding and nutritional habits. That can be rehabilitation, it can be even social workers. So in this slide, you see a whole team that might be involved in the follow-up, each with their own role, of course, but for an adequate approach of the combination of risk factors, this is extremely important. And finally, in a lifestyle intervention, it's even more complex. It's shared decision making, as is shown in this slide. Attitudes of patients are important, attitudes toward risk factors, assessment of symptoms are important. So the clinical team does not work on its own. The clinical care team, it is influenced and has to collaborate also with experts from other areas to come to a adequate and multidisciplinary approach to the cardiovascular patients. Finally, again, rather, these might sound like complex ways of working if you are involved with a multidisciplinary team, but fortunately, technology has advanced enormously. Electronic technology and electronic consultation might be extremely useful in these multidisciplinary approaches, by video conferencing, by telephone visits, or other ways of remote monitoring. So in good approach, these new styles, and this has been reviewed in this very recent study in the British Primary Care Journal, the various approaches that can be applied with electronic devices show an optimal way of follow-up of the patients and their treatment. So to summarize, and in the form of a few take-home messages in this video lecture, first of all, hypertension and hypercholesterolemia constitute a very dangerous combination, and it is seen frequently in clinical practice. Secondly, in more than 50% of the patients, treatment still remains uncontrolled. The effect is not effective enough to have adequate control. However, patient education, lifestyle interventions can be important additional approaches to help and tackle these inadequate forms of control. And finally, I believe that electronic forms, electronic consultations like video conferencing, telephone visits, and other ways play an increasing importantly role in the achieving adequate control of patients with both hypertension and hypercholesterolemia. I thank you for your attention.